previously served as COO, in which capacity he oversaw healthcare services, network management, e-business marketing, product development, consumer operations, and Blue Shield's 3 business units offering medical and specialty benefits coverage. So I think this is a great, we have here with us tonight sort of the 3-legged stool, you know, physicians, hospitals, and payers. And it will be interesting to see whether or not, and if they do come up with the same trends and their different takes on what those trends will be and how they will affect both their own fields as well as patients and consumers and our healthcare delivery area as well. So what I would like to do very briefly is I'm going to just take a couple of minutes to give my take on the trends. I have a couple that came. I've actually, this is a confession. I cribbed these from my annual lecture that I give as the first lecture I give in my Managing Health Delivery Organizations class. So I borrowed that. So we'll see if my trends also are in alignment with the trends of the experts here. Okay, so these are not in any order other than how they came out of my brain, not in any order of importance or anything like that, just a few different things that seem to come up. One is that we're having increasing, hopefully, the hope is that we will have a decrease in the silos between physicians and hospitals, as well as the external environment, and this will lead to increasing coordination. Obviously, the aging of the population is going to affect the demographics and the way we provide care, and that has all kinds of implication for home care, chronic management, chronic disease management, et cetera. There's a variety of workforce issues as well, with shortages of physicians, changing in licensing for physician extenders. The millennials are having their impact on the way we provide care, being much more technology savvy and demanding more of that in the way that we as organizations respond to their needs. Increasing organizational and clinical alignment in order to meet the population health needs that we have. A variety of new management competencies, all of which we will need to develop teamwork and collaboration for previously siloed individuals to be able to work together, do-it-yourself healthcare, and on-the-job health, where we have organizations and employers giving out Fitbits, having on-site clinics, doing a variety of different techniques like that to incentivize their workforce to be more healthy. Information systems, of course, I think everybody knows about that, but those are increasingly more and more sophisticated. And while we haven't gotten there yet with interoperability, I think we're moving in that direction. Certainly, organizations and provider organizations that share EHR, i.e. either Cerner or Epic, are moving toward being able to share some of that data, and that's a big move forward. Financials and insurance, the fact that insurance companies and payers are now aligning and partnering in a variety of different ways on the provider side, rather than just being in contractual conflict and negotiation, is a sign that different things are changing. So we have population health and continued consolidation with a variety of different partnerships forming, not just horizontally across medical groups or across hospitals, but vertically as well. Increases in technology, as I said, with the insurance, with narrow networks and access, crowded EDs, all of that is going to be addressed. And finally, transparency, increasing transparency as the consumers demand to know what is going on, both in terms of quality and in terms of price, and this transparency is going to create demand for the competition and for organizations to do that if they want to continue to be competitive. So that said, I'm going to now ask our panelists to talk. Hope I didn't take any thunder from you guys. I just kind of tried to sort of lay the groundwork, but all of the analysis and the sort of deep thinking that goes into this and explaining it and where they think it's going to go is all going to go with them. And we're going to start with Don Crane.
So I guess I push this little thing to on at this point. It's red. Is it green? Went green. Good. Thank you, Diana. So it's a pleasure to be here. Exciting times to be sure. The challenge we've been given, we three speakers, just to forecast what's going to happen over the next 12 months, which I find interesting because I could probably quite readily predict what might happen over the next 5 years or 10 years, because I think the macro sort of direction of where we're all going is pretty clear. The next 12 months actually is a little harder to talk about. It's very short term, so it'll be really an interesting kind of challenge. Quick word about CAPG, better update my bio, frankly. We Californiaized our name here a year or so ago in connection with our national expansion, as we've taken on members from outside of California, and we now have a lot of those. In fact, we have a footprint in 38 states, I think, in Washington, D.C. and Puerto Rico. Kind of a sign of the times as the rest of the nation starts moving into risk contracting and so forth. Well, they look to CAPG for sharing best practices and so forth. Capitation is really what distinguishes CAPG. So almost all of my members have at least a significant percentage, if not over half of their revenue derived from prepaid capitation. So, you know, we're there in terms of risk contracting and alternative payment model, and we've been there for a couple or 3 decades, learning, trial and error, a few stumbles here and there to be sure, and not anywhere near the optimum or perfect state, but we've been at work at capitation for a long, long time, and we're now watching what I think is a movement towards that very same trend across the country. So that's CAPG. I think I've got 10 minutes or so here to kind of cover the subject. There were 3 things that I thought I would talk about. The first being the SGR bill, that at considerable length, because I think that is huge, frankly, bigger for our purposes at least, or CAPG's purposes and maybe our purposes tonight, even than the Affordable Care Act. Hard to believe, but it's that big. Next, I'll say a word about ACOs, because I think they're going to be sort of so important, both Medicare and commercial. And then finally, a word about sort of the marketplace and the consolidation and the like that we're seeing going on. So, SGR bill, so we all heard that, what was it now, 6 or 8 weeks ago, probably a good 2 months ago, the Congress passed the bill that fixed the whole SGR. They repealed the formula by which the Medicare fee schedule is updated or not updated each year. So we've read with, I think, frustration over the last, 13 years, how there have been patches and how they've had difficulty addressing increasing or not increasing the amount physicians are paid in Part B. So that's the professional side of Medicare. We're talking original, or also known as traditional Medicare. So the Senate, all but 8 senators voted in favor of this bill, and all but 37 congressmen voted in favor of this bill. That bipartisan, bicameral vote with that kind of a margin is very important, because it says something about the durability of that law as to whether it'll be repealed or replaced or something in the future, and also says something about whether either party, and in fact they have not, kind of claims an intellectual ownership over the contents of that bill, okay? So passed by a big margin. So what's that bill all about? Well, the headlines that it attracted were that it repealed the SGR formula, right? So all of a sudden we're not tied to kind of an arcane index that they continue to ignore. Instead, they've replaced it with a completely new system, and that's what I want to talk about, because I think it is of really big importance, bigger even than the Affordable Care Act. So in 2010, we had the ACA. Obama signed it. It ushered in very important insurance reforms. It gave us the exchange. It gave us the individual mandate. It gave us, I think, another 30 million or so people covered, and in California now the uninsured rate's down to like 7%. So don't mean to belittle it. Its changes are deep, profound, and big, but for our purposes as a physician group, professional association, it did little, frankly, in terms of delivery model reform and payment methodology reform. Yes, there were little bits about medical home, and yes, the Medicare Shared Savings ACO program got its start, but not a lot more, not much more than that in terms of delivery model reform. Race forward to now the SGR fix, though I don't think it was well known by anybody at the time, including not well known, frankly, by the congressmen and the senators that passed the bill. It included these provisions that created a very stark fork in the road. So come 2019, we're in 2015 now, physicians across the United States, all of them that are practicing any kind of Medicare, so we're talking about all the internists, so much of the spend is in Medicare, right? And it is indeed a market leader, and we'll talk about that in a minute. All of them are going to be facing two stark choices. They get to either join a MIP, a Medicare Incentive Payment Organization, or that route, not an organization, they either go the MIP route or they go the APM route. And the APM stands for Alternative Payment Model. So the MIP route is kind of the default one. And basically, it is a combination of three existing programs. I think they kind of create four of them, but it includes meaningful use. So the whole EHR adoption piece, PQRS, the kind of nascent quality measurement program within Medicare, and I think another program or two. So they're now going to be looking at resource utilization and quality metrics. All that gets rolled up into MIPS. And as physicians look at that fork in the road, they get to see that if they're in the top half of the class, there's going to be a curve. Medicare's going to measure physicians on their performance and grade them. If they're in the top half of the class, they stand to get bonuses. They get an increase on their Medicare Part B compensation. It's graduated, it's phased. It's, I think, in the first year 2%, and then the year later, two later, it's 4%. Goes all the way up to 4%. So perhaps an attractive looking picture to some physicians. They do really well, they can get some more money. But to do well in meaningful use and in those quality measures, you almost have to belong to an organized system to exchange data, store data, transmit data to measure quality, to satisfy the meaningful use requirements, phase 1, 2, and 3. It's kind of hard to be Marcus Welby in an individual independent practice of old on a street corner. So, and then the other way to look at MIPS is if you're in the bottom half of the class, flip-flop that into a reciprocal and you'll face penalties in the same amounts. So you might not just get 100% of Medicare, you'll get 98, 96, all the way down to 91% of Medicare over the course of the years 2019 to 2025. So a physician will be looking at that fork of the road, and he may say, or she may say, look, I'm really good, I'm going to do well, I'll get paid more money, 5 minutes, thank you. Or I don't want that competition. They'll then look at the other fork of the road, and this is where I think 80% of the physicians are going to go. That is my prediction, and we'll see that by 2019 and subsequent years. It's in the alternative payment model where, on a relatively easy basis, if you have at the outset 25% of your Medicare business in a quote-unquote APM, alternative payment model, to be defined in regulations that have not yet been adopted, you'll get an automatic 5% bonus. Not just on the 25% that's in the APM, but all of your Part B business. So you have a relatively easy task. You'll just have to do something you may not have ever wanted to do, which is join an APM, which may be a synonym for IPA or ACO, frankly. And that goes on from from 2019 to 2025 or 2026, I think. And then after that point, there's a cliff, basically, where for everybody in an APM, you'll get, I think, a 0.75% increase in your Medicare fee schedule. If you're in the MIPS, you'll get, I think it's a 0.25% increase. So between those two forks in the road, physicians will see difficult and dangerous and not particularly lucrative and potentially, including penalties, or much easier. So I think they're going to take the APM route in droves. So I'm predicting by 2026 and thereafter, we're going to have 80% of the physicians in the United States are going to have at least a toe or maybe a leg in the water in terms of alternative payment models. So what might they be? Medicare shared saving ACOs. They might be bundled payment arrangements. They may be medical homes. They may be other programs generated by the Innovation Center or out of CMS. But this is going to represent a sea change for the United States. You can say goodbye to the sort of Marcus Welby, independent, utterly autonomous, disconnected, fragmented, fee-for-service physician. Medicare is leaving that in the rearview mirror. So the importance of that is beyond just Medicare, however, because it's certainly my view, and I think that of many people, that Medicare, as goes Medicare, so goes much of the market. And that's really true in some states, Kansas or something. You know, you'll have Medicare having a big slice of the market and maybe one or two commercial plans. Now here in Southern California, we have a multiplicity of plans. It's probably less true, but even so, Medicare is a powerful market shaper. So I think as we look to the future, while I'm now predicting 6 years out and I'm violating my mandate of trying to guess what the next 12 months, you're going to start to see some recognition, people positioning. I think the AMA and CMA are going to have to wake up and see what they've done, basically. And people and physicians and organizations, IPAs are going to see this as a recruitment opportunity. And physicians will be moving into basically accountable kinds of systems where quality measures have a big impact on. So that's really number one. Number two, and I'll move pretty quickly here, we are soon to see the next batch of ACO regs. So I'm talking about the Medicare Shared Savings Program, which has been struggling, to say the least. The pioneers in California, I think only, or across the nation, only a quarter of them made any money. That's true of just the shared saving ACOs. It's been struggling. The design of it is difficult. It is an open network, go anywhere you want to, fee-for-service platform, and it has produced gains in quality, but it hasn't produced profits yet. So in terms of being a draw, it is not. If the new regulations don't fix that, I fear it's going to falter even more. So this one I will predict. In fact, we may see these regulations in like the next week. Our annual conference is next week, and so the timing, we got to get this right. But anyway, so we're actually hoping to see them like today. They're at OMB right now, so we may see them at any moment. So let's keep our eyes out on the ACO regs and think about their impact really on the attractiveness of Medicare ACOs. And the final point I'll make in my waning seconds here is, as always, the marketplace is going to be really interesting. So we've been seeing a lot of consolidation and mergers, hospitals buying hospitals, health plans purchasing groups, groups merging with groups. That kind of trend is going to continue. It'll probably accelerate. I think at its heart you will see a kind of gravitation towards physician groups where population management is the name of the game. Thinking ahead towards risk-based models where quality is going to drive cost. That's where the competency is going to be needed, and that is what's attracting health plans and hospitals, and that's why they're acquiring physician groups. So there's my hook. So there's my 3 points, and that's my prediction.
Okay, next up, Tom Prisolak.
Let's see here. So good evening, everybody. Glad and happy to be with you as well. I think Diana hit all the right points, so let's just move to the Q&A. Like Don, I struggled with the assignment for the next 12 months, and so I've taken my own poetic license with the evening, and hopefully it'll come close to what we were asked to do. One of the things we were asked to do is to begin just to make a quick look back on the last year, and I'll try to do that very quickly. I think there were a series of environmental factors that I think are worth commenting on. There's some comments about the cost trends and the quality trends. With regard to environmental factors, I guess the one I would refer to is the exchange and the development of the California exchange, which on the commercial side, I believe has about 1.3 million enrollees at this point, which is at the lower end of what I think was expected. And so you can infer from that whatever you'd like in terms of the progress that the exchange was making. The other part of the past year, I think, that surprised a lot of people, were the number of people now enrolled in Medi-Cal. Some 1/3 of the population of the state of California now enrolled in Medi-Cal, which has, I think, a lot of implications in terms of the statement it makes about the socioeconomic status of the state and implications for things like healthcare status, given, as we all know, the implications of socioeconomic status for one's healthcare status. This past year also saw the implementation of the California Dual Eligibles Project. Those of you not familiar with it, those are on Medicare. These are poor Medicare patients who have been basically, large numbers of them have now been moved into Medi-Cal managed care networks. That implementation was not entirely smooth and had its own challenges. It does raise, among other things, the question of whether or not these patients had been moved into Medicare Advantage networks as opposed to Medi-Cal managed care networks, and what implication that might have had on the difference. Commercial insurance market dynamics, I would say, we're starting to reach the early childhood, perhaps, of the post-ACA world. I think there have been evolutions and development in the networks. The networks are broadening somewhat, and there's a certain stability. I don't mean to suggest that it's finalized at all, but certainly more stability than the prior year. And on the provider side, as has been referred to, there's really an evolution that's going on away from hospital organizations and physician organizations to what I think is rightfully called healthcare organizations. And that's happening around the state to significant degrees. On the cost side, I think there is good news on the cost side. All of us would like to see cost decline. But we've been on several years now where the cost trend has been much more moderated from previous years. And in last year, I think went up a little bit over 4% in terms of total spend, while a lot more people are now enrolled. And so that has to be considered as well. And then finally, on the quality side, if in the interest of time, I can go into this in more detail in the Q&A. But I would say that on the quality side, hospitals and physicians are fully engaged in this question. There's an organization called the Hospital Engagement Network here in California, includes some 400 hospitals. There's been a collection of activity that they've undertaken that have made real and significant progress in a number of quality measures, and among other things has resulted in some 9,000 lives being saved as a result of improving quality and safety and saving some $70 million. So that's a quick look for the year that we just finished. Maybe I even bailed out more, Don, than you, so I can't predict the future for the next 12 months all that well either, but I can identify a couple of levers that I think will be the basis on which more specific things can be expected to occur. So the first is the next round of ACA implementation, and the question there is whether or not there will be, in fact, more success in getting more people enrolled in the exchange that has occurred to date. And there's now this new introduction, the current interest in expanding coverage for those who are currently not eligible for the exchange and what the implications of that might be. With regard to the deployment of value-based payment models, I would just echo the comments that Don made, that both on the government side as well as on the commercial side, the movement towards more and more value-based payment systems of one type or another is going to continue. I would observe that the movement to capitation has not been as dramatic as many people expected. And so I think we're likely, for the coming year at least, to see a continued mix of capitation and other value-based payment models. And to his point about the government being a market mover with regard to hospital payment, CMS's announcement this past year of wanting to have, I think, by 2019, 80% of all Medicare payments in a value-based payment model, I think will be a significant issue for the field. And then finally, as Diana referred to, there will be more and more public reporting on both quality and cost, but there are potential issues about that, and I'll speak to that in a minute. Further levers that I think will drive the evolution of the system is the whole phenomena of the development of these integrated healthcare organizations that I referred to in the beginning, as hospitals and physicians begin to work more closely together, and then those hospitals and physicians, either through direct ownership or through strategic partnerships of one type or another, will work hand in hand with the rest of the healthcare continuum: home care, skilled nursing, acute rehabilitation, all of those pieces. Because the world we're going in, and if the world we're going into, and Don alluded to this, requires a level of clinical, managerial, and financial capacity that really doesn't exist, certainly in many physician practices, and frankly doesn't exist in many hospital organizations as well. And so that is what's going to inevitably move things in that direction. I think there's going to be a focus, more and more a focus on individuals as well as whole patient populations. And what I'm referring to there is the interest and the focus on this whole question of patient engagement, largely driven by the convergence of digital and mobile and the development of an incredible array, frankly. The private equity world is on fire right now with companies that are pursuing one aspect or another of patient engagement for purposes of improving stickiness in the marketing term, but also more importantly, for improving the quality of care and the quality of care that people receive. At the same time that all this is going on, good old-fashioned stuff, the kind of things that places like Cedars-Sinai and UCLA and other academic medical centers have been doing for decades is going to continue. And we will continue to see the development of I think some pretty remarkable developments with regard to advances in science and medicine that will fuel, allow us to ultimately fulfill the promise of personalized medicine. We're seeing a lot of that in cancer right now, but I think it will move more and more into other fields as well. I think a trend that we've already seen and will continue in the future is increased alignment between payers and providers. In the current world, all of us suffer from, quite frankly, from the fact that people move around so much from one health plan to another and otherwise. And if that cycle is going to be stopped, at least from my standpoint, I think that's probably only going to stop as a result of better partnerships and more enduring partnerships and relationships between the provider community and the payer community. And then new levels of collaboration among payers, providers, and government. And in that regard, I would just refer to the CMS Healthcare Payment Learning Action Network that was announced, where there's an effort to try to bring together the leading health plans on the commercial side as well as the federal government. So all of those are the levers, and that's, if maybe I can call that the what, then to me the real question is how those things get done, how they get done, and exactly there are a series of decisions that can be made within all of those levers, and how they get done I think will have a big impact going forward. With regard to the ACA, there's the Supreme Court decision, which on its face will not have much impact here in California because we do have our own state exchange. But the unknown is the political process that could be launched as a result of the plaintiff succeeding. If the plaintiffs succeed, that will create a certain amount of instability, and the question will be what kind of political process will play out for possible changes related to tweaking the ACA as a result of it. I think another environmental change has to do with, the ACA rather, has to do with, in this coming year, there's going to be an increase in those eligible for the small group market, moving from 50 to 100. And as that eligibility changes, and the implications of that, I think, could have some significant impact as well. On the public reporting side, from my standpoint, there's really an urgent need to both consolidate and harmonize all of the quality measures that are going on. It's really creating quite a challenge, frankly, and I think is both a barrier to the kind of progress that people want to see, because there are so many disparate measures that are out there being measured and reported on. And frankly, it's also creating confusion in the public. There was a health affairs article published in the last couple months that identifies, I think, some meager number of people who are actually looking at this information and using it for decision making. And that's because depending on which survey you see, you won't see any alignment. You won't see any commonality between which is the best hospital or which is the best physician group. There's a great amount of disparity. With regard to the efficiency measures, I think the efficiency measures are only they're in their gestational phase, I would say. They haven't even been born as a baby or an infant. And therein, I think, is a real challenge, because the development of efficiency measures will call into question a lot of unanswered topics with regard to payment policy and how current payment policy plays out in the delivery system, and how that payment policy, especially government payment policy, gets reflected in commercial insurance prices. An important element in the future is the provider's obligation to achieve the benefits of integration. So consolidation or merger is not the end. That's not the point. Providers have a great obligation to get the yield out of that in terms of improved efficiency and improved quality by achieving greater degrees of integration between the hospital, the physicians, and the other parts of the healthcare spectrum. So the real work is integration, it's not consolidation. And then finally, there are a whole series of things in the policy world that, depending on how those things get implemented, will be a challenge. If there's a theme that I would say in closing, is the need to reconcile new policy decisions with the regulatory mechanisms that are underlying the current environment. I'll leave you with one example. Medicare is very interested in moving to site-neutral payments. That is taking away a distinction between the amounts paid to hospitals compared to freestanding facilities. A noble goal and appropriate conceptually. But if the regulatory environment that makes the hospital environment more expensive than a freestanding environment is not changed, then that will create a much more chaotic environment. And that's just one example of a series of potential regulatory conflicts that I think will need to ultimately get reconciled. Whether those get done in the next 12 months or not, I don't think so. And so that allows us to come back 5 years from now. So thank you.
Okay, excellent. Okay. Paul Markovich.
Okay. Good evening, everybody. Thank you for having me. I found it interesting that in the midst of being asked to make predictions, that Moore's law, the law about the pace that semiconductors' capacity and efficiency will improve, it just turned 50 years old. And Gordon Moore was interviewed, and he was asked whether he learned anything about having made this incredible prescient prediction. And he said, yes, I guess one thing that I've learned is once you've made a successful prediction, avoid making another one. So one prediction I will boldly make is in 12 months from now, there will be no such thing as Markovich's law. My predictions will not be that good. I will take the time to make a few bold predictions about Blue Shield since I'm up here. We will remain a not-for-profit company. We paid over $300 million in taxes in 2014, and we will pay a very large bill going forward. In case you're wondering, if we do not keep our tax exemption in the state, that bill will go up by $25 to $30 million, so probably less than 10%. And whether or not we are tax exempt, I predict that it will not impact our not-for-profit status, and that the public and the media will continue to confuse and conflate the two issues. And after a prolonged and intense marketing effort, 50% of the California population will still confuse Blue Shield with Anthem Blue Cross. But fortunately, 75% of our employees will actually know they work for Blue Shield. And my last prediction about Blue Shield is that the Care First acquisition will actually be approved in the next 12 months. You know, we perhaps have been a little bit too trained from ACA to follow instructions, because I've followed them to the letter, and I have 5 predictions for the next 12 months. Just please don't bring me back to see if they were true a year from now. And they are these. Federal subsidies will be maintained at least through 2016. There will be at least one large-scale acquisition. I mean large scale as in like Humana gets acquired. I'll talk about that. Many California providers will pursue what I call the illusion of control, or the I can be Kaiser 2 approach. None of these will get substantial traction, and at least one will be abandoned. We will pass legislation in California that makes specialty drug pricing more transparent. And finally, the long-term winners in healthcare will be actually changing healthcare on the ground. So those are my 5 predictions. I'm going to talk a little bit more about why I think those things are true. First, with the federal subsidies, if you were to survey my colleagues, CEOs of health plans, they would be far more pessimistic than I am. So I am in a very small minority in this point of view. But I believe either the Supreme Court upholds rules for Burwell versus King, or if they don't, they will allow for some kind of transition period. And because I think they're very concerned about the impact they might have on real people's lives. Now, after that, of course, political self-interest takes over. But as much as there's a number on the Republican side that say, I would never, ever support anything on Obamacare, the reality is there's an awful lot of registered voters in purple states and swing districts who will lose their subsidies and will know where to point the finger. And so I think at the end of the day, it is in the political self-interest of Republicans as well as Democrats to at least extend this beyond the presidential election and have the fight later. So I am predicting, whether the Supreme Court rules for it or against it, at least federal subsidies continuing through 2016. Second, there will be at least one large-scale acquisition. Historically, when you look at these patterns, acquisitions tend to follow a pattern, and as stock prices appreciate over a period of time, folks want to go out and buy something, or they find it a good time to sell. And so, and if you take a look at how health plan stocks in particular have appreciated over the last 18 months, they've gone up quite a bit. And you're hearing sounds already. You hear Anthem saying, we think we're in a good position financially to make an acquisition. Humana came out last week and said, companies have expressed interest in acquiring us, and we might take a look at that. So, you know, those are the sorts of things that where, of course, we're acquiring CareFirst, but I'm not talking about something at that scale. I mean, you could see something very large potentially happening, and not just potentially in the health plan world, it could also happen in the provider world, but I think something big will happen in the next 12 months. This provider pursuit of what I called the illusion of control, or the Kaiser model, I want to be clear, I deeply believe that the path forward is going to require much more integration amongst the three players: health plans, physicians, hospitals. The only way we're really going to drive the systemic change we need to is we figure out how to sit around the table together, make it more efficient, make it higher quality, achieve the triple aim. So I'm a deep believer in that. I am a skeptic of an ownership model of all three legs working very effectively, because if you look at what's happened over time, and there's good reasons for it, it's been the exception to the rule that model has actually flourished. And in some respects, when you see this happening and you see all kinds of providers applying for Knox-Keene licenses, buying physician groups, trying to be a health plan, it feels a little bit like Yogi Berra, right? Deja vu all over again. We have seen this movie before. And it's generally based on the fundamental belief that if I have control, the world will be a better place, right? When you peel it all back, that's really what it is. If I own it, good things are going to happen. And why I don't think it's going to work is that most of the folks that are trying to consolidate and pursue this, first of all, you need money. To get a Knox-Keene license, to keep it, to have the capital to take on that kind of risk at that scale, you need money. The providers that tend to have that kind of money are generally large hospitals and hospital systems, predominantly. And they generally got to that point because they get a higher reimbursement level than their neighbors. It's one of the reasons they have the capital that they have. If you want to go compete on price with Kaiser or anyone else for that matter, generally what you're doing is having a very narrow network, right? It's me, and I just want me in the network, and I want the membership to come to me. Well, there's a price elasticity out in the marketplace where if you're asking any customer to trade off for one of those broader networks for a smaller one, you expect a price discount. So if you're a hospital and your average reimbursement is here, or your reimbursement is here and the average reimbursement in that neighborhood to commercial health plan is here, you need to get your cost reimbursement well below that level in order to hit a price point that allows you to compete. And so the math generally doesn't work unless you're on the ground driving changes in care, unless you're making it more efficient, right? Unless you're reducing the readmission rate, re-engineering the discharge planning process, unless you're doing those kinds of things and doing them aggressively, it's very difficult to make a price point hold up. And in the meantime, there's a lot of capital, fixed costs in being a health plan, in complying with all the rules and regulations that you need to be a health plan. And you're getting reimbursed at a much lower rate than you are with any of the other membership that comes in. And so it's a very challenging thing to figure out and do. And it's the reason why in the past so many of these things have fallen apart. And providers have often sold them, or they've kept them at a very, very small scale. So I think what you're going to see is a number of folks burning through a lot of capital and not coming out to the promised land. And I would not be surprised in the next 12 months if at least one of them potentially pulls the plug on being a provider-owned health plan. Specialty drug legislation. It's interesting, when you wake up in the morning, as I did this week, read the paper, and someone like Dr. Leonard Saltz, a Sloan Kettering oncologist, gets up in front of a group of his colleagues and says, these cancer drugs are too damn expensive. You know something's changing. And we have been a part of a process to introduce more transparency legislation for very expensive drugs, saying we ought to understand how we got to this price, what the financials are behind it. And at the hearing for that, there were health plans, healthcare providers, consumer groups, labor groups, business groups, consumer groups, going up saying, we really ought to have this. And then on the other side, we had effectively the Pharma Trade Association. So when you just look at the cost of these drugs, and Leonard Saltz was calling out a couple of examples where new drugs would cost $300,000 for the average patient. In one case, $1 million if you took the per year. In another case, we really just can't afford that as a society, and I think there's going to be a demand for more transparency. And the last thing I just want to say is the winners are going to be folks that actually change care on the ground, irrespective of whether ownership changes or not. It's going to be about, do you have the will and the skill to drive the triple aim, drive cost improvements, quality improvements, improvements in patient satisfaction? Can you bring healthcare into the digital age? And the story I often tell is in the same day I went into the office, I used my phone to get a car, I used my phone to do a banking transaction, I used my phone to pay for parking, to go visit my primary care physician, and then when I walked in the door, I got handed a clipboard. So it's the folks that figure out how to solve for that, bring healthcare in the digital age, they're going to make a difference. So with that, I think we should probably get to questions. Thank you.
Terrific. Yes, please. Okay, so that's terrific, and there you have it, 3 very different perspectives from 3 becoming more closely aligned parts of the healthcare area. Do we have microphones? Okay, so I'm going to open it up to questions. Jack, you're first. You raised your hand first.
Hi, I'm Jack Needleman, chair of the Department of Health Policy Management at the School of Public Health. Those are 3 terrific presentations. I probably have about 3 dozen questions for you. I've been trying to figure out which one I wanted to actually ask, and I'm still not sure I've got the right one. You focused very much in thinking about what's going to happen in the next 12 months on where you sit. So we heard a little bit about how health plans are likely to evolve, how physician groups are likely to evolve, how healthcare systems are likely to evolve. I didn't hear a lot of discussion about patients. We talk about increased integration. We talk about changing digital environments. You've talked about increased bundling of payments and increased changes in the metrics for evaluating each of your organization's performance. Each of those have risks for patients as well as potential gains for patients. And I'd like to know how you think over the next 12 months the patient experience is going to be changing in beneficiary experience is going to be changing in your organizations? And on balance, will patients be happier or less happy at the end of the next year?
So I'll be happy to make a stab. It sort of depends on which patient you're talking about. I mean, there's many things to be said in response to that, but briefly, a big thing that's going on now across the really.
Let's focus on the 20% who are actually going to cost us the 80%.
So I was going to say the 5% that drive the 50% of cost. That's precisely what I'm after. So certainly what my members are doing now, like never before, is data mining to stratify the population, find out who that 5% is or who that 20% is, and then bombard them with services to keep them out of the hospital, keep them healthy, and keep them happy. So if we look at that swath of the population, I think they're going to get better care than they've ever gotten before, because that's where the high cost is, and that's where the quality initiatives really need to be focused in the main. So that's, there you'll see a very patient-centered kind of work there. The other end of the spectrum, invincible 25-year-old surfers and so on who sprain their ankle, I don't know that the world's going to change a lot for them. It's a very kind of episodic thing. But the whole business about risk stratification and then outreach to the higher intensity patients, that's sort of the name of the game right now in terms of population health and population management. So we're going to see a lot more of that.
Maybe I could just add briefly that, you know, I think for all of us, and I know Tom and Don pretty well, that it really is all about the patient. So if our comments didn't come across that way, we kind of are using shorthand when I say things like triple aim. It's really all about about that patient. So I think we're all pretty centered there. I think in a 12-month period, they are going to be happier. I don't know that we're going to have dramatic breakthroughs, but we are going to see things that do matter. For example, there was a fair amount of confusion with the smaller networks that were introduced in the Affordable Care Act. I think there's going to be much clearer information that's available, much clearer understanding of the product that I'm buying and the network that I'm buying. I think some of the just basic information, services will have improved and will take away some of the noise that folks experience. And I think you're going to see incremental shifts and changes for the folks that are the sickest, that cost us the most.
Yeah, I would second the point that I think all of us have the kind of the patient's interest at the heart. It was embedded in everything that we were describing. I think with regard whether people will be happier or not, I'm not going to make that prediction either. But I will say this: I think by all of the objective and professional measurements of providing a higher quality, more clinically cost-efficient care for those patients and other patients, I think we will be a year's worth of incrementally further down that road in significant improvement as a result of a whole host of interventions being done both in the ambulatory setting, in the physician component of our organization, as well as in the hospital. So dealing with everything from the patient's when the patient's discharged, the transfers to skilled nursing facilities and back, all of those interfaces. The convenience of patient access, being able to be seen in a timely way. I made reference to patient engagement and the use of mobile technologies. We've got a whole agenda, like many other organizations in town and around the country, making use of that for those patients that I think will enhance. Here's what's going to continue though for some time. The American healthcare delivery system is I don't know, I'm trying to find the right description. Quilt. It's a patchwork of different kind of systems. So everything I'm describing to you is the things that can be brought to bear for those patients who are being treated in organized, coordinated delivery systems. There remains today a significant number of people who are treated in you had a great list of adjectives: disorganized, uncoordinated care. And for those patients, some of whom come to the hospitals of the healthcare systems I was just describing, who have the capacity to deliver it for those who are part of the integrated system, those patients may have a different kind of experience. Now, everyone's also working to try to make that uniform across the spectrum, but it takes a lot more effort and takes a lot more time to be able to deliver that kind of capacity outside of the integrated segment.
One thing I overlooked. Patients are going to hate the high deductibles. So there's going to be problems in terms of the financial side. The healthcare's still too unaffordable,
Right.
and so they may love care or hate care. One thing that's going to be big time, and that is the backlash against high deductibles. Get ready for that soon.
I just may call out also I thought, there's, when we say there's incremental improvements to treating the sickest of the population, probably more apt way to describe it is, I think there's going to be breakthroughs, but they're not going to be everywhere. They're just going to be in smaller places. It's going to take a while to scale those up. And Tom, for example, was telling me about some of the major advances they've made in their hospital on this front. I know we've introduced this oncology practice of the future in a couple places, and it's dramatic what the patient is experiencing, but it's only a small number of patients in that geography, and getting it spread so that it gets to thousands or millions of people takes time.
Other questions?
I guess this would be for Mr. Markovich. What role do you see insurance companies playing in medical tourism?
Medical tourism, well, to me, the way that I look at everything through our lens is we have a mission. It's to ensure that all Californians have access to high quality health care at an affordable price. And the way that I talk about it inside our organization is that means our job is to transform a dysfunctional system that's bankrupting us into one that's worthy of our family and friends and sustainably affordable. So that is the litmus test for whatever we do. God forbid one of your loved ones needs to access the system. A, can they afford insurance and access it? And B, when they get there, are they getting treated the way they ought to, the way you'd want them to at their time of greatest need? So when we think about anything, creating an ACO, contracting with a provider, the question is, does it further that goal? And I don't know the answer on medical tourism, to be perfectly honest with you. And there's a tension point, I think, in the healthcare system between a couple different philosophies that are ultimately going to need to come together. One is a philosophy that says, well, let's just make the member, the patient, a customer, right? Let's give them all this information. They'll do cost and quality. They'll go shop for their MRI. They'll go shop for their prostate exam, right? And there are benefits that you can get from that. They're limited. If someone's having a heart attack, you don't want them grabbing their phone in the ambulance and figuring out which quality criteria to look at. Or it's like, no, take an aspirin and just get to the hospital, right? So, so medical tourism probably falls in that, well, I can compartmentalize the procedure and put it over here, whereas there's a whole lot of evidence that when you have an integrated approach, if you do it well, you're going to get a lot, you're more likely to get to the triple aim at the end of the day. I do think in the integrated model, we have to figure out how to get the patient or the member more engaged with financial incentives so that they are a part of the conversation. And some of the things that are happening on the patient as a customer side can be very helpful for that. So to me, I don't know the answer specifically to medical tourism, other than that's the lens that we look through. And I think we have to be careful not to take this patient as a customer notion too far, because in the process, you can lose the opportunity for coordination and integration.
Okay. Yes, young lady.
Hi, you mentioned in your presentation about federal subsidies that will be maintained in the next year, and also you said that at least one large-scale acquisition will happen. Since both are two intertwined, and also what was mentioned during the presentation is that there will be high deductibles as well as high costs for oncology drugs, what do you think would happen to costs at the patient level and in general at the aggregate level? Thank you.
What's going to happen to premiums, you mean? Or costs? I didn't quite hear the very end of the very most important part I didn't quite catch.
Yeah, the costs at the patient level and then the
Yeah.
costs at the macro aggregate level.
Well, I mean, the good news has been, if you look historically, is healthcare trends have come down from where they were. That's the good news. The bad news is that the costs are still outstripping wage inflation. So when we look at what is affordable, we've gone out and said what we call is the total cost of ownership. So it's not just the premiums we charge, it's the typical out-of-pocket payment somebody has to have, because that way, otherwise, look, anyone can make something. I can go out and do a $20,000 deductible if regulators allowed me, and I could be affordable overnight. But it's not really affordable, right, for somebody on the ground. So we look at the total cost of ownership when we benchmark our plans, so you don't get into this benefit design, high deductible thing, kind of cheating your way to saying you're affordable. But if you look at today, if you take our most popular product, total cost of ownership, family of 4 in California, it costs over $16,000 a year. Wow. The median income for that same family is between $60,000 and $65,000 a year, which means if they were paying for it themselves, it would be more than 26% of their gross income, not their take-home pay. Right. That is not affordable. And every year, price inflation for premiums outpaces wage inflation, which has been around 2%. It gets worse. And so that is why, to me, these integrated, coordinated approaches, the deep integration that I was talking about, working that with a sense of urgency, probably with a select number of providers in smaller networks, is going to be key to getting to that triple aim and including affordability. In the meantime, I think what we're going to see is probably fairly stable at the macro level, most products. But that still means an already unaffordable product in many respects is getting more unaffordable and is not sustainable.
I would only add to what was just said by Paul, that I think he's accurately described the pricing situation and the individual. You know, total spending in the country is going to go up. And it's going to go up. We are, in spite of all the work that you're hearing described, and I have to say, I think, you know, as I talk and meet with colleagues around the country, what we're talking about here tonight is happening in delivery systems around the country. There's a lot of incredible work. The challenge is some just fundamental underlying demographics. There are 8,000 baby boomers turning 65 every day. Every day, 8,000 people. And the attendant realities of the aging process that come along with that will be very hard to overcome to really significantly moderate total spending. And that's where this squeeze that we're talking about is going to get worse.
I'd also like to thank everyone for your presentation. It was very informative. Tom, you brought up the issue of 30% of the marketplace in California being Medi-Cal. Mm-hmm. One of the issues that is a major concern, I think, in the LA area is accessibility for that population and finding physician specialists that will take care of those patients.
Right.
With the influx of all these patients now demanding care and thinking that they have insurance, they're ending up in our emergency rooms for care, and we are trying to refer them out, which is an impossible job. What I'm wondering is there any strategy, not that I expect that this group is going to come to that solution, but is there any strategy between the insurance industry, the physicians, the hospital industry, and the government to improve the number of physicians available? Because whether we have physician extenders or whatever, our system is still based on physicians providing medical care or guiding the system.
Right.
And that's a question that needs to be answered.
Yeah. I'm unaware of any kind of coordinated effort of the kind that you're describing that's out there. I think, and I think the issue, that's where the whole discussion about the amount of Medi-Cal payment rates comes to bear on this particular question. With regard to the physician supply question, there are a number of new medical schools, I think, about to be launched in California, but that's an 8-year, that gets you down the road 8 or 10 years from now, right? So that's not going to be a tomorrow issue. So I think the problem you describe is going to remain with us for quite some time. In the meantime, institutions, I think, are looking to care for these patients as much as they can afford to care for them, But there's a real issue related to the relative payment level for Medi-Cal patients compared to the real cost, not what anyone's charging for it, but what the real cost of caring for them is, and the implications that has for commercial prices. There's some $8 billion worth of underfunding for Medicare and Medi-Cal in the state of California among hospitals alone, that 95% of which is borne in the network model health plans in the state. Probably commercial prices, in the hospital commercial prices could come down by 30%, rough number, 30%, if the losses being sustained under Medi-Cal weren't with us. There's no real discussion going on about that kind of phenomenon.
John, do you want to?
Well, I was just going to say, there is a debate, of course, about physician supply. Certainly one of our views is that if the physician supply we currently had, if those physicians were deployed in doing what they should be doing, we'd have enough physicians right now. So presently, 30% of the cost is spent on care that's unnecessary or frankly wasteful. So if you peeled that out, that would make a big difference. If you were really using team-based practice as it should be done and using mid-levels and the team properly, you would be leveraging the services of those physicians more efficiently. Were that done universally, we'd be having enough physicians. We would have enough. The real issue on Medi-Cal, though, is the reimbursement so absurdly and ashamedly low. I mean, it's like 60% of what Medicare is or less, and so on. And there are efforts underway, legislative and otherwise, to fix that. There are other sort of programs, almost gambits, to generate revenues to match the federal match and so forth. The hospitals have one, the nursing homes have one. We're trying to do one to elevate Medi-Cal compensation to Medicare or community rates. But they're one-offs, they're small, they're transitory. We just really have a fundamental problem of Medi-Cal being just really ridiculously underpaid. That's the problem. The access would change overnight. If Medi-Cal were paid at Medicare rates, the access problem would change overnight.
Could I ask everybody to introduce themselves before they ask their question, too?
Scott Flax. What are your thoughts around employer groups and how they may influence, or bend the curve in terms of change in healthcare over the next 12 months or so, especially since they bear the cost burden for most of the healthcare today?
Yeah, I think they have a major role to play, and it's not even just in what products they purchase and how they go about that, but those decisions, especially for larger purchases, look, they're a customer and a major customer, so the health plans are going to try and jump when they ask us to do something. So they have a chance to influence there, but even more so, and this isn't talked about so much, is think about how much time people typically spend at work and how much things like how sedentary you are in your workday, how that has incredibly pernicious health effects if you're too sedentary, the kinds of meals that are available. There's incredibly small things that can add up to really big differences on life and health habits that your employees have when they're in the workplace. And so beyond just, are they buying value networks that are trying to do this type of integration and this work that we've been talking about? Are they moving to plans and providers that are trying to be technically integrated in the way I described and getting out of the clipboard business? I mean, those things can help influence care. But as much or even more so, I think, is there a cafeteria nearby that provides healthy options? Do you have an option? In every one of our work sites, we have an option to have a walking workstation. You can walk up to 2 miles an hour while you're processing a claim, answering the phone, et cetera. Are you creating that kind of environment where people can be moving, active, easily making good lifestyle choices? Those things can make a really big difference.
One trend that's worth noting is that, employers are angry. they are unhappy with the kind of spend that they're facing now to cover their employees. Among many things that could be said, though, is that they're moving from insured products into the uninsured world. So there's the question. So the ERISA self-exemption is attractive to them, where they avoid a lot of the costs associated with the kinds of quote-unquote consumer protections that are found in the Knox-Keene Act. So we have a very unhealthy trend going on where they're moving from fully insured, HMO, coordinated care kind of products, shedding all of that to move into self-insured, where basically it's PPO, and they can have high deductibles, thin benefit designs. There isn't a lot of coordination. It really is not what Sylvia Burwell, our Secretary of Health, has asked for, which is a movement towards risk-based contracting, 50% by 2018 and so on. So we really have an amazing trend in the state here, California, which is really sort of the fertile crescent or something of coordinated care. We have this movement from not volume to value, but from value to volume among a lot of employers. So it's counterintuitive, but it's one thing that's happening.
I just add that there are many employers actually that are pursuing a number of creative strategies to deal with this issue. The Safeways of the world, the Boeings of the world, a number of companies like that, doing a whole variety of creative kind of contracting models. The other thing, and actually none of us I think brought up specifically, but private exchanges are something that I think a lot of folks are looking to. It's largely being used as among other things, as a mechanism whereby employers are moving, though, from a defined benefit plan to a defined contribution model in the course of going to the private exchange approach. And I think we're likely to see significant growth in that area.
Could one of you please explain a little bit more in detail how private exchange works?
Sure. I mean, it really is just a situation where there are a number of benefits consultants and other organizations that are creating a grocery store, for lack of a better term, of health plan options and putting them in a package and saying, well, this collection of plans, this collection of insurers are all available, and then you just set a contribution, as Tom said, so defined contribution. Here's how much money I'm going to give you, employee. Go shopping. But you're going shopping in a controlled environment with specific options. There's often risk sharing and risk adjusted premium involved in that, because you can imagine how risk selection might occur with that many plans. So that's just the general notion of it. All the mechanics that you get on the covered California state exchange, you kind of just copy, mimic, and present to a specific employer group.
With the increasing role of government as payer in a lot of instances, whether it's through federal subsidies, through exchange, whether it's through Medicare, through the growth in Medi-Cal, and the strong potential of another Democrat in the White House, do any of you think we're going to hear the clamor for single payer?
No.
I think we're going to continue to hear noise, and some call for it. I think, though, that a very instructive lesson we saw recently with Vermont, where they had teed up a single-payer system for that state. This is a matter of months ago, and a strong movement, and I think it passed both houses of their state legislature, and then they basically scuttled it. The governor and their legislature scuttled it because they finally, I think, realized that it was cost prohibitive. So maybe the leading example of a single-payer system was withdrawn by the very architects of it. So that's a lesson, I think, perhaps. It's tough healthcare is expensive, and so it's tough to be a government paying for all of it.
I just find interesting, by way of observation, that while an increasing amount of the payment is starting with the federal and state government, when you think about subsidies for the exchange, Medi-Cal, Medicare, they're also increasingly looking to the private sector to help. So an increasing portion of Medicare beneficiaries are going through the MAPD program. And at the state level, they're pushing more and more into managed Medicaid, including doing a dual eligibles pilot. The exchanges are all private plans. And so it does beg the question, this is where generally the single payer efforts fall over, isn't it better if we have single payer? Great, now what? Right? And so how do you actually go physically pull this off is a question and actually finance it is a question where it often falls down.
Just to elaborate briefly, part of the issue is Americans love choice. Sure, all kidding aside, I mean, as a cultural matter, Americans love choice. And I think that unless someone can come up with a way of architecting a single payer or tax financed, which is the better way of describing it perhaps, system, and that can still have elements to it that can satisfy Americans' love for choice, I just don't see there being enough social acceptance in order to get the political will to do what you're describing.
We talked about data mining, digitizing, personalized medicine by way of cost. We're getting closer and closer to people's genetic information being a part of their personal health record. And your comment about choice is very much a part of the question. How do you control the outreach of health payer organizations who are reaching out to higher risk populations? When you have their genetic information, how does your outreach not turn into coercion? Thank you.
Is that directed at me, or is
I wasn't. All kidding aside, I wasn't really. I was kidding aside. I wasn't clear whether your question was related to the provider side or the health plan side of it. Seriously,
It's
or
really
both.
related to the whole issue of public health care.
Right. Right. So I get what I would say is I think that that individuals' genetic information in terms of how it's treated today is treated with the same privacy protections that apply to other medical information. So whatever providers have in their medical records regarding the genetic profile of an individual in their medical records would have the same privacy protections that all medical record information has today, whether that's someone's blood pressure or their weight or their obesity score, things of that nature. So that's the best answer I can offer from the provider side.
One other thing I'd add is that underlying the question is the notion that insurers and providers would eschew patients with a bad health profile revealed in some genetic testing, right? And it's largely true. But the point I'll make is that for my members, now they actually do well with acutely ill patients. This is a big change. We actually now, provided that we're paid actuarially sound, risk-adjusted capitation, we do best with those seniors that have multiple chronic diseases. So the logic underlying this is if, for example, we learn that someone is, through genetic testing, has a propensity for chronic disease or something like that, my members in many cases would want that patient provided they're paid adequately for that patient. That's where we do our best work. The reason I make that point is that there's really a kind of a paradigm change that occurs when you ask providers to take financial risk, and that's underway right now. So I just throw that into the mix as I don't give you a very good answer, that the way the psychology of delivery will change is going to change as well.
I would just say I'm not really worried about it turning into coercion or people being left out in the cold because of some greater level of detail for all the same reasons that Don mentioned. I actually worry far more about data security. And I don't know how many of you noticed that with the data breach on Anthem, there was a couple of months afterwards that a Washington came out and they said the most likely candidate for having done this is a Chinese-sponsored government hackers. And so let's just assume for the moment that was accurate. You're talking about potentially trying to keep this data secure from nation states. And they are extraordinarily sophisticated and very persistent when they want to get after something. And so I think one of the things that's going to need to happen, because we're talking about more and more data, which is needed if we're really going to get to the personalized medicine, which I think we all want to, and is going to hit that standard of care that's worthy of our family and friends. We're going to have to cooperate and coordinate more about how we make sure this data is secure, because any one institution on its own is going to have a hard time standing up to a foe like that's that persistent and that sophisticated. So I worry much more about the overall security in our current environment than I do about any kind of coercion.
Hi, Ron Clausen, a student of the School of Public Health here. My question is, with the upcoming adoption deadline for ICD-10, do you see any significant impacts for your organizations, excuse me, coming within the next 12 months?
A lot of physician depression.
Yeah, much higher use of Prozac and other.
I think the ICD-11 policy pushing is probably going to have to go on hold. Yeah.
Yeah, no, all kidding aside, I don't think folks understand the degree of impact this does have on physicians. And we had the topic we haven't talked about is there's a growing amount of physician and other provider fatigue out there with all of the changes that are going on. And ICD-10 is going to just be kind of the next one. And it's going to be a challenge.
The irony is that we've invested so much to get ready for ICD-10 that recent suggestions that it be delayed, we've actually opposed. Right. You know, we hate it. And that's probably the wrong word. I think it's better to say we've worked so darn hard breaking our neck to get ready for it. Just bring it on, or leapfrog it entirely, and let's go to ICD-11. But I mean, I think Tom's right. It's just a ton of work and expense to get ready for a massive coding change for everyone.
If I just may take 30 seconds for an infomercial here, I do think this is a great example of we got to be much more thoughtful about when we introduce regulations. There's a whole lot of people that think there's all these different things. The amount of things that we're mandated to do as a health plan, that Tom's mandated to do as a hospital, it ends up being busy work. And I mean, ICD-10 is not about changing care on the ground, doing the things we've been talking about, achieving the triple aim. It's a lot of work and a lot of energy, and it's actually a big opportunity cost from working on the things that are going to be much more impactful. And so I think it's a great lesson learned as we go forward, and there's all these potential clever ideas of what we all could do and should be mandated to do, is if you're going to do that, let's make darn sure it's high value. Because if it's not, let us just get busy trying to make this happen.
Meredith Lynn, question for Don. In terms of the SGR fix, what impact do you think that will have on participating physicians in Medicare? Looking at those two options, or do you think that the demographic shift really is going to cause them to say, I've got to do something? How do you see that playing out?
So you heard my prediction that the great majority of them will go into APM. With that, you mentioned the word demographics, which is really key. Faced with all of physicians of the world are overwhelmed with all of the administrative work, the multiplicity of different quality programs, all the administrative work. The demographics are really important. I mean, I think into my answer I would sprinkle the following. For physicians that are above a certain age, let's just say 60 or something, you're not going to get a lot of adoption of new stuff. They're going to ride it on out through their retirement, which would be a logical thing to do. On the other end of the spectrum, physicians coming out of medical school right now, they've never known anything but a digital world, and they want it and they expect it, and so you'll get high levels of compliance of all the stuff we're talking. In the middle is a sort of a different picture, and that's where physicians are trying to figure out where they sit in the world. Do they really, they never really wanted to join maybe Kaiser, but they might do it now because it's in their economic benefit. They never really wanted to be in an IPA, but now they'll do it. So the demographics, age, and gender also, and life-work balance issues and stuff will play a role, but I still think they're going to be pretty much obliged to get into organized system because so much of what we're talking about requires systemness, and that takes capital, it takes know-how, it takes management, it takes all the stuff we've talked to. So we are moving into a world where we're looking at sort of organized systems, whether they're just physician group-centric or hospital-centric, whether they're the perfect menage a trois of plan, group, and hospital, whatever they are, they're gonna involve sharing of information and personnel and savings and profits like never before. So that's how I would answer that.
We need to take at least one more question. I can't have that picture in my head.
Okay, we need at least one more question. We actually have time for 2 or 3 questions, so why don't we do 1, 2, 3 in the back.
Rod Shader. I wonder if you have any comments on the effect that in the short term that parity legislation might have for behavioral health services, which historically have been both underfunded and underintegrated with the rest of healthcare, and the fact that with healthcare stratification, risk stratification, in that awful 5%, there's a high prevalence of substance abuse and mental health problems. Do you see this as having a short-term effect on shaping healthcare in the next year?
I think on the physician and delivery side, actually unrelated to parity, but I think parity enhances it. There's already been a movement started to basically strengthen the mental health component of all these organizations' capacity on the service delivery side. It's an example, actually, I think, of where the integrated coordinated model and capitated payment provides the incentives that can, I think, turbocharge that kind of move, because there is so much of a comorbidity related to mental health in so many patients, and particularly the high-cost patients. It's part and parcel of it. So if to the extent that the payment model moves more and more in that direction, then I think you'll see the parity legislation be helpful in that regard. What that has from a total cost standpoint, I defer to my colleague to the left here.
No, I think if it's done well, I agree. I just want to say ditto, because if it's done well, this is, I mean, it's going to be a beneficial thing. It's ultimately going to improve quality, and I think long-term it'll improve cost, because everything I've seen on this subject is folks that have those conditions tend to bounce around the system. I mean, they have lots of comorbidities, and they're trying to, they have this pain, and they're dealing with it in other ways. And until you figure out what's really at the source of it, you don't get the quality of care, and the costs are extremely high. And so I think doing it in this system and doing it well will ultimately be the right thing all the way around.
Plans who didn't offer initially to go on the public exchange, if they're going to start maybe, hey, now water's good, we're going to come in, and if people who initially signed on, if they have, expressed satisfaction with the metal level they chose initially, or if you're seeing a lot of movement, people who, think silver 1 year and they're like, no, doing platinum this time, things like that.
Well, I don't know, Don, did you want to?
No, put me in the queue.
No, that's fine. So, yeah, it's a broad question. I'll try to answer briefly. I think overall, net, if you step back, you've got to be pleased with how California has handled this and launched it. I mean, as much as the 1.3 or so million that are in the program now are very much at the low end of what was forecasted after the second year, the fact that there's that much membership in it and enough critical mass that you don't have what you have in some other states, which is a real big risk selection problem. Small population, nothing but the sickest, potential, they're dealing with or potentially having to deal with serious death spirals. There have been certainly, it has not been a perfect service rollout, but it's been much better in the second year than it was in the first year, and I think it's going to get even better the year after that. The outreach to minorities, for example, has improved. The Hispanic population the second time around, that's been documented. A lot of smaller networks have been included, and there was just a recent article about the fact that the quality of those networks in fact, is maybe a little bit higher than the broader networks that have been put in place. What I see needing to happen, just when I look into the future, is the way that it was initially set up. It made far more sense for a health plan like ours to do a directly contracted fee-for-service model, and for all the reasons we did it that way. And yet what we're really looking for ultimately is a much more integrated model. And I think that's what you're going to see a movement to in the coming years as this matures, and now we understand it and we know how it works. We know how we might do, for example, risk-adjusted premiums along with risk-adjusted capitation in a way that could work. I think you're going to see more of that movement.
So that's Paul's final point that I was going to pick up on. That's our problem with the exchange. Much about it is really to be applauded, frankly, particularly when you compare it with other states. But from our perspective, the exchanges, as we look at it today, snapshot, is almost devoid of capitated accountable care. I mean, it's almost all PPO and sort of EPO, where plans are contracting directly with physicians, moving us in the wrong direction, the very opposite direction that policymakers want us to go. That trend needs to be reversed. Paul's alluded to that. There's systematic and kind of structural problems that give rise to that, but we need to fix that, because if it's marching us in the wrong direction, then I don't think it's going to serve us well. So that's an interesting factor.
Ditto to what's already been said, I would only add, I alluded to this in my comments. So the first year, I think both on the provider side as well as on the health plan side, people took a conservative, cautious posture on every angle, every element of the contracting piece. And comes year two, I think the picture's a little clearer. People have an understanding of where things are. And as happens in markets, new equilibrium points, begin to be found, and I think that's a part of the story for the second year as well.
Okay, we have one final question, final short question, Frank.
Sure you used. We talked about the abysmally low rates of Medi-Cal in the state, and there's a lot of medical groups that are members of Don's organization that have Medi-Cal managed care contracts. Paul's company just bought Care First. These contracts are, of course, fixed rate. And so now in Los Angeles, we have the Los Angeles City Council passing with the mayor signing an increase in the minimum wage law. I don't know how much this affects. I can tell you in some of the groups I work with, it's upwards of $1 million a year. Those rates will not be offset, I don't think, unless the state has a fit of rectitude and they want to make things right. So I don't know how we adjust to that. I don't know how it's going to affect things, but it could be a problem. Any comments?
Is there a question there?
I think the only thing I'd offer, Frank, is I think when that situation occurs in other areas, it could trigger consolidation. So that those who can't afford it becoming part of those who can figure out how to absorb that in their larger entities. That's speculation.
I mean, I think I just go back to the global comment I made about the fact that all of this goes back to it's not affordable at its current level and not sustainable. The state doesn't have the money, federal government doesn't have the money to keep paying at this level. And the way that governments tend to deal with issues is they just change prices. I mean, and that's not just the U.S. government. You look all the way around, you look at other systems in other countries, how do they manage healthcare costs? They just squeeze prices. And we have to figure out in all these populations how we can manage to make it affordable and high quality. And fortunately, with the way the system is right now, you have to improve quality in order to get sustainable affordability. So there's no tension point between those two. But we got to figure this out, and when we can, then there's enough money in the system to make all this work. But we have to figure out how to make the money that's in the system work. And when we do that, we can deal with all that.
Excellent. Well, thank you very much to
That was fun.
Great
That was fun,
job.
Fred. Yeah, well done.